we are going to transition to a compare and contrast session here. And if you just look around and everybody on the call, we're all in different practices. Some of us are in private or private-demic practice, like Serena and I am. Others are in academic practice. And then and Ron is in a managed care type setting. So we all have different obstacles. We all have different things that could either help or inhibit our transition to outpatient arthroplasty. So we wanted to compare the private setting to the academic setting, and Serena is going to take us through his experience at Rothman.
So thank you, Quinn, for running this. Thanks to San Diego Shoulder for allowing us to do this, as well as OrthoBullets. I think the legacy of Jimesh lives on with dedication and years of educating shoulder surgeons around the world. Thank you to the board and John Ticker and JP Warner. Okay, so my disclosures are relevant in that I have ownership in my practice, and we'll talk about that in great detail. But as we all know, shoulder arthroplasty has dramatically shifted to the outpatient setting. This is driven by a lot of factors that were discussed by the other speakers, including patient and surgeon preferences, creation of specialized outpatient centers, cost, and of course, removal of total shoulder from the inpatient-only list. Currently, there are 250 physician-owned hospitals approximately, and almost 6,000 overall hospitals in the U.S. 9% of orthopedic surgeons are actively involved with a physician-owned facility. While the growth of physician-owned facilities has been restricted by the Affordable Care Act of 2010, ambulatory surgical centers have boomed, and there's continued to be rampant growth over the next 10 to 20 years. So I think this talk will make a lot more sense if you understand the background of our surgical environment at Rothman. We're a private practice. We provide orthopedic care and educational services to Thomas Jefferson. We also do the same for several other health systems in the region. And importantly, Thomas Jefferson is a partner with us in our two orthopedic specialty hospitals and many of our ASCs. For over 10 years, we have taken on this approach of demand matching. This is a term that was used extensively by our former CEO, Mike West, and basically means that we indicate patients for surgery at specific facilities based on their medical and social comorbid conditions in order to optimize outcomes, provide most efficient care, and to reduce costs. This has been attractive for insurers because it means that patients who do not need the resources of an inpatient facility can have their surgery performed at a lower cost facility like an ASC, and feeds our personal goals of providing optimal healthcare at a faster and less costly manner. When it comes from the surgeon standpoint, I think there are really, in private practice, 3 reasons to do outpatient total shoulder. It's a better patient experience, it's an improved surgeon experience, and then there's the financial incentive. As surgeons, I think we all recognize the pains of working in a tertiary care center where the incentives don't always align. The anesthesia team may be slower in order to get through their shift with overall less work. The OR turnover team may have a little less hustle when it gets close to the 2 or 3 p.m. witching hour where the teams turn over. And meanwhile, the surgeon is just trying to get the day done. Our anecdotal experience has been borne out in our research. We've shown that an orthopedic specialty hospital results in reduced length of stay, improved operating room efficiency, and a high safety rating. But the elephant in the room is that all the stakeholders in the delivery of care, from the patient to the insurance company to the hospital system, all have a financial incentive, and those incentives don't always align. So the answer is money. What is the question? So from a financial standpoint, it's important to understand that the Medicare payment to the surgeon is the same, regardless of where the surgery is performed. I think many of us understand this. The facility payment changes, and these numbers change, but if you look at Medicare payments to an ASC, it's approximately $13,000 and about $18,000 in the hospital setting. So we've looked at how much the actual cost is reduced by doing surgery on an outpatient basis at an ambulatory care center. And it's not that different than doing it in a hospital setting. It's almost $1,000 difference. OK showed similar numbers in his talk, but the difference in the facility fee is actually fairly dramatically different at about $5,000. When you look at the surgeon reimbursement, the hospital payments have increased over the years. The surgeon payments have declined. So clearly, we're not doing as good a job as the hospital systems at advocating for our interests when it comes to reimbursement. When you think about the financial incentives, that's what we're talking about here. If you're Jefferson Health System or any health system, your incentive would be that as many total shoulders are done in your tertiary care hospital as possible. Because not only do you get the facility fee at a higher number from Medicare, but you take on 100% of that facility fee. You don't have health partners necessarily. When you think about it, their second best option would be for us to do our surgeries at our specialty hospital, where we still get a hospital facility fee, but they have to share it with us and with a management company. And then the surgery center would be their least favorite place for us to do total shoulders because the facility fee is lower and it has to be shared amongst the other stakeholders. From our standpoint, if you look at a private practice, we would love to do as many of our surgeries as possible at our own specialty hospital because we get the highest facility fee because it's considered a hospital, and we share in that facility fee because we are part owners. The second best place from a financial incentive for us to do it would be at an ambulatory surgical center because, yes, it's a lower reimbursement, but we have ownership in it, and so we share in that fee like OK was talking about. And from a financial perspective, the worst place for us to do our surgeries would be at a tertiary level hospital. So why would you do it? Why would you do outpatient surgery? And I think there are a lot of reasons. There's altruistic reasons. We think about patient satisfaction, lower cost to the health system in general. And then there are personal reasons where it's your satisfaction with a facility that may run more efficiently. You may be trying to stay more competitive in your environment by offering outpatient surgery, home the same day marketing. You get to share in the savings and the earnings potentially, depending on what your arrangement is. But we have to be careful what we wish for. The hip and knee colleagues have gone through this experience of transitioning to outpatient, and we're seeing some shifts as well. So if you look at the trends in shoulder and elbow procedure reimbursement for arthroplasty procedures, it's been steadily declining. So this is obviously concerning because we're doing more, we're doing things more efficiently, and by doing more and doing it more efficiently, in some ways, we're making it seem less valuable to those who are reimbursing it. The unintended impact of knee arthroplasty going to outpatient only has been a lot of paperwork. And many of you have probably seen this in your practices with shoulder arthroplasty. I know I have. Insurance denials for inpatient arthroplasty for patients who clearly need it. I've seen patients with walker dependent with no care at home with multiple, cardiac stents, and still it has to be booked as an outpatient and then has to be changed on the back end, which adds significant administrative time. So, I think that in my personal situation currently, I try to do as many patients as I can in our orthopedic specialty hospital. This allows me to discharge patients or keep them the same day. So I think that it's a very safe place to do outpatient arthroplasty. If they need to stay, they stay overnight. And if they're unhealthy and they can't be done at that hospital for reasons of medical comorbidities, then I do them at the tertiary level hospital. I currently do not do outpatient surgery at a standalone ASC because our standalone ASC is not credentialed for it, and so it's not really an option for me right now. If I was to do it, I would think about starting off doing it at an ASC that's honestly geographically closer to the main hospital. Currently, the ASC that I work at is not close enough for my comfort in case somebody needed to be sent over. So I think it's clear from all the talks that you've heard, it's here to stay. The interest in how aggressively you shift your practice to an outpatient practice, I think, is partially determined by your ownership in whether it's an ASC or specialty hospital, or if you're a stakeholder in the main tertiary hospital. I do think it's important to have a bailout. So for me, the hospital, I can keep the patients if I need to. The strategies that all the other speakers spoke about how to demand match your patients to the appropriate center are critically important, and you need guidelines for which patients are allowed to be done at an ASC or a specialty hospital safely. And then clearly from everything that we've seen, we need advocacy with CMS and private insurers to try to at least quell the decrease in our reimbursement. Thank you.